Okay, we're going to open the second session. Hopefully we won't have to take time off the discussion session, so we'll get started right away. This session, we have two speakers. The subject is culture, health, and the functional GI disorders, and I think it's going to be a very exciting and interesting session in which we get the perspective that we're not always exposed to. So we will start.
So I am pleased to introduce the first speaker. Dr. Streltzer is professor of psychiatry at the University of Hawaii School of Medicine. He is the current president of the International College of Psychosomatic Medicine. He has published widely in the areas of psychosomatic medicine, pain and prescription opioid dependence, and cultural psychiatry. He has published extensively on culture and psychopathology and cultural competence in healthcare.
Thank you very much.
Just using this to any slides will be there.
Oh, okay. Thank you very much. In Hawaii is a multicultural society, and we're all kind of interested in culture. Everybody's a minority there. Today I'm going to give an overview of the ways that culture influences the practice of medicine, and I'm going to focus more toward the end on the way that medical culture can actually influence the way we treat patients. How does this work? Okay, good. Culture has been conceptualized as representing the totality of behavior patterns, customs, values, and beliefs that make a group of people unique from other groups. Culture is not the same as ethnicity, even though the terms are sometimes used interchangeably. Ethnicity refers to a distinctly identifiable group of people because of a common historical path. Members of an ethnic group often share the same culture, but not necessarily. Think of an immigrant, say, to the United States, whose cultural values and beliefs may be distinctly different from a member of his family from the third or fourth generation. Several trends have contributed to the development of interest in culture within medicine. In the middle of the 19th century, large numbers of European immigrants came to the United States. They were sometimes thought to have more mental and physical problems due to a fundamental inferiority. Today, the health problems of immigrants are hopefully treated without bias. Cultural factors are considered related to their specific health problems, however. In the 20th century, cross-cultural research, often stimulated by the World Health Organization, has been carried out to compare the prevalence of illnesses in different societies. Generally, disorders with relatively less well-understood etiology are much more likely to have cultural influences than disorders that have clearly defined biological bases. Examples of medical disorders that have been considered to have important cultural influences include fibromyalgia, chronic fatigue syndrome, low back pain, whiplash, and irritable bowel syndrome. In recent years, there has been interest in the promotion of minority health. The Institute of Medicine has documented numerous disparities in health care among minorities. Minority is not the same as culture, but this concern has been accompanied by a focus on the doctor-patient relationship and cultural competence. The minority person may indeed have a different cultural background from the host culture, but this does not have to be the case. Nevertheless, the minority person can be subject to bias and also more easily misunderstood by a healthcare provider who is not a member of that minority. Recognizing that the minority person has a unique personal background with cultural elements, as does every person, should help eliminate bias and perhaps begin to reduce the disparities in healthcare. Culture has been of concern in medicine because it is an important determinant of behavior, which can in turn influence disease through a variety of mediating factors, such as diet, smoking, use of alcohol and other drugs, activity levels, and compliance with medical management. Lifestyle behaviors can influence the spread of contagious diseases, such as AIDS. Furthermore, culture affects medical care not only with regard to episodes of medical conditions, but also in the presentation of symptoms and the doctor-patient relationship. Cultural competence is a term that is being increasingly seen in the medical literature. It not only refers to the need to recognize cultural factors in disease, but perhaps more importantly, to the ability to maintain useful communication and a therapeutic doctor-patient relationship when the patient is from a different culture or subculture. Consistent with this, culture is being defined more broadly to include groups with a variety of commonalities beyond society of origin or ethnicity, such as sexual orientation, socioeconomic status, disabilities, and minority groups in general. Primary care medical specialties in the United States have begun to emphasize the need for cultural competence as well as certain specialties. Effective communication between doctor and patient requires an alignment of the doctor's approach with the cultural perspective by which the patient views the world and puts his or her illness in context. Disagreements between patient and physician about the patient's health status and the effectiveness of treatment are thought most likely to occur for conditions that are stress-related or have culture-specific associations. From a broader perspective, healthcare systems are striving to become culturally competent. Recommendations to achieve this have included instituting programs to recruit and retain staff members reflecting the cultural diversity of the community served, using interpreter services or bilingual providers for patients whose primary language is not English, cultural competency training for healthcare providers using linguistically and culturally appropriate health education materials, and creating culturally specific healthcare settings. Thus far, few studies have attempted to evaluate the outcome of these programs, however. Here is an insurance company advertisement stressing how important cultural competence is for healthcare. In a medical setting, three types of cultures are present and interact with each other, namely the culture of the patient, the culture of the physician, and a specific medical culture. The culture of the patient contributes to the patient's understanding of an illness, perception and presentation of symptoms and problems, and adjustment to the illness. The patient's expectations of the physician, motivation for treatment, and compliance are also influenced by the culture of the patient. The culture of the physician superimposes on the physician's personality traits and professional knowledge and will shape the pattern of interaction and communication with the patient. For example, a physician may be influenced by cultural prejudices or biases toward a particular gender, male or female, sexual orientation, say gay or lesbian, race or ethnicity, specific disease, say AIDS or alcohol dependence, or certain medical procedures, such as abortion or euthanasia. The medical culture refers to traditions and practices that have developed within the medical service setting beyond medical knowledge and theory. Whether the physician and nurse work together as egalitarian team members or in a strictly hierarchical order depends on the medical culture, as does society's choice of a socialized or privatized medical system. The anthropological literature describes observations of the American doctor. The dominant values are individualism, mastery over nature, an orientation towards future and eventual cure, actively intervening, aggressively controlling, and fixing the patient are the usual attitudes and approaches for the clinician, reflecting American value systems which may not necessarily be shared with other cultures. Much of the literature that recognizes cultural differences in medical practice emphasizes differences in orientation between Eastern and Western societies. For example, a comparative study revealed that 95% of U.S. internists would inform patients with terminal cancer of their diagnosis, in contrast to 0% of Chinese internists surveyed. This study also revealed that when family members' wishes conflicted with the desires of the patient regarding chemotherapy for advanced cancer, Chinese internists were likely to follow the family's preferences 2/3 of the time. American internists would do so only 5% of the time. This is probably changing in recent years to some degree, and medical culture can change over relatively short periods of time. A United States survey that was published in 1961, most practitioners responded that they would not tell a dying patient of his cancer diagnosis. In less than 20 years, however, U.S. physicians, given the identical survey, overwhelmingly indicated they would inform the cancer patient of their terminal diagnosis, reflecting a dramatic change in American medical culture that persists to this day. The physicians in both these studies did not perceive their responses as being due to the culture of the times, however. In both studies, the physicians claimed that they based their decision to tell or not tell on their clinical experience of what was best for their patients. The needs and desires of the physicians themselves seem to be more at issue here than the needs and desires of the patients, demonstrating that cultural differences in medical practice can be a manifestation of a medical culture that is not necessarily imposed by the underlying societal culture, although there is presumably at least some influence from the societal culture. Perhaps even more importantly, medical culture greatly influences the treatment of painful conditions. Pain management is something that I'm particularly interested in. For example, the relationship of chronic low back pain to physical findings explaining pain and the related psychosocial dysfunction varies substantially by country. Some of this may be directly related to culture of the society. Some of it may be related to the medical care system, including the presence of entitlements for disability. This busy slide is just to point out that the treatment of chronic pain varies substantially by country, and in particular, it's hard to see on this slide, but the use of opioids chronically for pain varies tremendously in different countries. It's very high in the United States and Canada and some European countries and Australia, and very low in a number of other developed countries. In recent years, a pain management culture has influenced American medicine and that of some European countries. It may be considered a culture because it has specific values, beliefs, and practices with regard to the use of opioids for chronic pain. It minimizes or discounts any scientific evidence that does not conform to this belief system. Here's an example of a couple different cultural systems regarding pain, with a jogger and an alcoholic. A review of opinions from the medical literature, internet discussion groups, pain societies, and patient advocacy groups in the United States over the past 10 to 15 years reveals a firm belief that opioids are efficacious analgesics even when given chronically on a daily basis. Scientific evidence is weak in support of these beliefs, however, and in fact there is much evidence contradicting them. In particular, chronic opioids result in a cascade of cellular adaptations such that physiological responses to chronic opioids are quite distinct from responses to acutely administered opioids. The chronic adaptation includes tolerance, hyperalgesia, and probably craving, all by distinct mechanisms. Thus, chronic opioids seem to enhance sensitivity to pain, let alone induce tolerance to analgesia. The phenomenon of hyperalgesia and chronic opioid intake has been the subject of several recent reviews with the conclusion that there is scant evidence of efficacy for the use of opioids chronically for pain and certainly not in high doses. This is just one of the studies that the mechanisms of enhanced pain sensitivity have been described at the cellular level. There's an induction of a number of neuropeptides. Dynorphin is one of them that causes enhanced pain sensitivity. And simultaneously, over the last 15 years, there's been a tremendous increase in the prescription of opioids in the United States, Canada, and some other countries. And this is the United States. And as they have increased, there's been a tremendous, almost exponential rise in the number of emergency room visits for prescribed opioid analgesics, reflecting the morbidity associated. And most troubling is this recent article in the New England Journal of Medicine, which documented the tremendous increase in unintentional deaths from prescription opioids that has developed also simultaneously with this movement. A summary in an article by Manchicanti of all of this states that Americans, constituting only 4.6% of the world's population, have been consuming 80% of the global opioid supply. Apart from lack of effectiveness, except for short-term acute pain, there are multiple adverse consequences, including hormonal and immune system effects, abuse and addiction, tolerance, and hyperalgesia. Patients on long-term opioid use have been shown to increase the overall cost of health care, disability, rates of surgery, and unintentional deaths. While most studies focus on somatic pain syndromes, increased sensitivity to visceral pain also seems to occur. Opioids are sometimes prescribed in high doses on a daily basis for chronic abdominal pain and are associated with an increased incidence of what has been termed narcotic bowel syndrome. In summary, culture influences healthcare in ways not only involved with the doctor-patient relationship and the presentation of symptoms, but also, perhaps even more so at times, by the prevailing non-evidence-based medical culture in the community. Recognition of all these factors is part of the movement toward cultural competence and offers an opportunity to enhance healthcare. Thank you very much.